by itself. So go ahead,
Well,
Stefan. The mic is yours.
Yeah, thanks, guys. So I can give you guys a full lecture on optimal insulin management, and that'll be part of my greater lecture on what we can learn from bodybuilders. So I don't know if you guys
yeah.
know this, but bodybuilders actually abuse insulin. Insulin is actually the most anabolic hormone. We're going to talk about testosterone today. Insulin is way more anabolic. So what the bodybuilders will do is they will do a really hard training session at the gym, and they're going to do then a protein shake combined with a lot of carbohydrate, about 100 grams of carbohydrate and protein. They're going to drink that and give themselves an injection of insulin. And the reason they do this is because then the insulin helps shuttle that energy into their muscle to create an anabolic effect for growing the muscle. But what do the endocrinologists tell our patients? They say, you need to eat a carbohydrate so that you can take your insulin. No discussion about training, no discussion
Right.
about insulin timing with carbohydrate and training. So, what does the diabetic end up happening? Well, they get fatter. They actually just grow more adipose tissue with time, they
Yeah.
just expand. So if we can take one piece of what the bodybuilders are using and apply it to the general population, we can have a lot better results for our patients. The timing matters.
Yeah. Those guys, Stefan, you are 100% correct because those guys know exactly what they're doing with protein and building muscle and optimizing their metabolic health.
Yes. And so I can go a full lecture on that too. We can learn a lot from these guys because they're the absolute
Hmm.
extremes. There's septic patients in the hospital extremes, and then there's the bodybuilder extremes, like the two extremes. And sometimes they're pretty unhealthy too, but they can also be very healthy too. And we can learn a lot from how they manage their health in these extreme
Well,
situations.
in your talk, I'm going to jump ahead here. Are you going to talk about using testosterone and other things for muscle growth?
Yeah, yeah. It's a greater lecture I'm building because I have a patient
Okay.
panel where
Not
I
not
deal
today
with.
though.
Not today. Today is going to be a
Okay.
bit more tame, I'd
Hey,
say.
Stefan,
Yes.
what's the point of giving the shot of insulin? You give a big bolus of sugar, glucose, the insulin is going to spike up right away. I
Mhm.
mean, that reminds me of giving insulin and glucose to treat hyperkalemia in the hospital. It
Yeah.
often resulted in hypoglycemia.
Yeah. 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 Drives potassium into the cells, but then yeah. And also, Stefan, something about that too is that you don't need a lot of insulin to drive the glucose into the muscles. Muscles will do it themselves.
Mhm. Yep.
I mean, that's one of the tissues that doesn't need a lot of insulin
Well,
to
well
absorb.
the thing that Stefan is talking about. First of all, the dose of insulin is going to be low. The other thing, you have exercise, which is itself is an antioxidant, and that will increase the sensitivity of insulin. So the harm effect of insulin, which is oxidative stress, neutralized by the antioxidant effect of the exercise. Plus, those people, they're already taking tons amount of antioxidants. So I'm not worried about the oxidative stress induced by
Mm-hmm.
insulin because it's a different category versus people eating cake, which is sugar, and then they shut themselves with insulin. It's like burning, and then they don't exercise, they don't give antioxidant. They are burning their blood vessels, which leads to severe and progressive peripheral vascular disease.
Kidney disease too.
By
Hmm.
the way, the guy who pushed carb loading for athletes, particularly marathon runners, Tim Noakes, eventually himself developed type 2 diabetes and became a strong advocate for low carb diets.
Oh,
And
wow.
he's a brilliant professor, and I know him online.
Wow.
Wow.
Great
I
guy.
agree. If they're doing it and it's not really like taking sugar, putting insulin, and the exercise does not match with it, and the antioxidant they're taking is not matching, yeah, they will end up with diabetic mellitus, and they will cause severe. They will progress the whole complication of diabetes, whether it's angiopathy, retinopathy, neuropathy. All of it will get worse, and I have a lot of people who are diabetic type 2, which all you need is to increase the sensitivity of insulin. You don't need to give insulin,
Yes.
but
Yes.
they prefer taking insulin. I don't know why. One of them, they say, well, because when I took metformin, it makes you lose weight, and I want to gain weight. There's lots of excuse. But what they do, seriously, they are taking sugar, cake, and then they inject themselves with insulin. Think
Mhm.
about it. You have two oxidative stress you're giving that will burn the blood vessels: the insulin itself and the sugar that they're giving.
And
Yeah.
the nutritionists tell them that's fine.
Yes.
No, it's good. They think that just their blood glucose is the end all. All they're going to do anything they can to adjust that, no matter what the other consequences are. And what I don't understand, maybe you can clarify, is if somebody has a perfectly functioning pancreas, why are you giving insulin?
Well, in fact, they're hyperinsulinemic, right? If they're type 2
Yeah.
diabetic. So it makes no sense at all. And that is the whole scam of type 2 diabetes, focusing everybody on the blood sugar level, the blood glucose
Yeah.
level, as opposed to reversing the disease, which is incredibly easy to do,
Easy.
frankly.
Yeah. Yeah. Yeah.
And here's the sham, okay? Even if they have hemoglobin A1Cs being controlled because of the insulin that they're giving, okay, we'll think, oh, you're good, your hemoglobin A1C. Well, the
Yeah.
insulin is causing oxidative damage, not necessarily oxidizing the glucose because you lower the glucose, oxidizing other parts, the LDL, the other structures of the cells that does not manifest in hemoglobin A1C, and they will end up with severe peripheral vascular disease with a risk of gangrene and infection. And that's why, the wound care businesses starts is high. It's all because of the mismanagement of diabetic type 2. There is a big problem with insulin monotherapy that's being advocated by the mainstream medicine, and that needs to be disrupted. Hopefully this book that I'm generating, it's going to be around 30 page, will lead to that. But I think we are here as a group, as doctors, we need to go ahead and advocate that in diabetic mellitus we need to have multi-therapeutic approach and focusing on insulin sensitivity, which you can do it with many options. I mean, it's not just giving antioxidant, it's detoxing the toxins, mycotoxin, Lyme disease, any underlying inflammation can cause insulin sensitivity, and any underlying chronic conditions can lead to insulin resistance. In addition to gut health, normalizing the sex hormone, especially the sex hormone. That's a big factor. People can be weaned completely from insulin just by by normalizing the sex hormone. If they have low estrogen, you give them estrogen, or low testosterone, or you normalize the ratio of testosterone with estrogen using progesterone and the DEM inhibitors and things that we do. So those itself, the progesterone itself it increases sensitivity of insulin, it vasodilator. So there is many options where we don't need this scam and the mismanagement that the mainstream medicine are doing in actually destroying patients. And most of the patients, they die because of this gangrene and infections and peripheral vascular disease and
And
stroke,
kidney failure.
cardiac arrest.
It's truly insane. The disease is characterized by hyperinsulinemia, yet they never measure the insulin level.
Right.
Yeah.
Never.
Yeah.
They just
By the
look
time the
at the
A1C
hemoglobin
goes up,
A1C.
yeah,
Their
by the
instinct
time that
is,
goes up, wouldn't you say that you've got insulin problems for 5 to 10 years?
yeah, absolutely. Absolutely.
Yeah, and especially when we are starting patients potentially on GLP-1 medications, we should always measure an insulin level because sometimes you'll see a patient with an insulin level of 30 on a fasting blood test.
Oh,
What's going to happen when you give them a GLP-1? How
GLP.
high can the insulin go before you develop pancreatitis?
Mm-hmm. Mm-hmm.
Exactly. Exactly. It's
Good
never
point.
measured. No traditional doctor measures the insulin level. It's
Why is
awful.
that?
Because they're just brainwashed. They think the hemoglobin, we used to call that Harvard numbers, right? You have a perfect hemoglobin A1C, a low LDL,
No,
and drop dead the next day.
yeah. Yeah. It's not funny, but it's funny.
Oh, geez. All right, we're going to get with the show
Stefan.
here. Tonight's lecture is on the pharmaceutical methods of increasing testosterone in men. And we're going to give you my clinical approach to this. But first, we have to ask, can we rely on official guidance as to what is optimal level of testosterone in men? What does the mainstream medicine say? If you go to the up-to-date, you have to get at least two, maybe three abnormal low testosterone levels for men. It has to be done at 8 to 10 a.m., which typically testosterone should be highest in the morning. So you should potentially measure the testosterone in the morning, and you have to get a couple measurements that are consistently low. Um, but the problem with this is there's a bit of a double standard currently in medicine. If you go to Up to Date, they're kind of liberal with testosterone usage when it comes to the transgender thing. So one, they say, well, you have to get so many low testosterone levels for a man to have it approved by insurance to prescribe testosterone. But on the flip side, like anybody who wants to convert themselves to a different gender can have all the testosterone they want. So this is the kind of the double standard we're dealing with currently in medicine. And it's important that we call this out. But there has been some good movement here. So this is recent. As of last month, the FDA took off those silly warning labels that testosterone causes more heart disease. So they did a new study, the Traverse study, and they found that there was no increase in cardiovascular risk compared to placebo on men receiving testosterone replacement therapy through transdermal methods. And so this is very nice. And thankfully, FDA is going to take all those scary labels off the product that we know were false. So why do we?
Black box warning.
Yeah, it was black box warning. That's right. Our pharmacist would know. So why do we want to increase testosterone in men? Well, men with low testosterone, they'll complain of fatigue, poor cognition, low motivation. They'll have a classic visceral adiposity, fat on the midsection, but also visceral fat accumulation. So if you look at MRI screening or DEXA body composition screens, you can see the fat that's on their organs a little bit better. It improves muscle strength, tendon and ligament strength. I think an orthopedic specialist, when they see a man in the clinic who has a tendon that's frayed, a rotator cuff, a labral tear, the first thing they should do is measure a testosterone level. These men will always have a low testosterone measure. And yes, you can do an operation, but this patient will probably be back to you within a year or 2 or 3 for another operation with another joint or ligament issue. So these men are falling apart. And so our orthopedic friends need to be aware of this, need to be measuring testosterone levels in men, and need to be optimizing testosterone, or at least, send them to a competent primary who can do it. But then also, Dr. Halassa, we were all talking about the insulin resistance phenomena. And at my practice, we have a muscle-centric medicine approach. We understand that when you grow the muscle becomes a better storage. It becomes better at storing energy. So the bodybuilders know this, all the athletes know this, muscle stores energy, and the testosterone, it helps grow the muscle. So if we want to reverse the insulin resistance, if we want to decrease the amount of insulin that we're using in patients, we want to decrease and deprescribe all the anti-diabetic medications, we need to focus on the muscle. And to focus on the muscle, you need to do nutrition, you need to do training, and then you need to do hormone optimization so that the muscle can grow. And that's how we're going to reverse the metabolic syndrome, which is a huge problem, as we were just talking about. So how do we do this pharmaceutical-wise? That's the point of today's lecture. So the endocrinologists, they are big fans of doing the selective estrogen receptor modulators and the aromatase inhibitors. And these are drugs that we're going to talk about more here. And we've developed a protocol thanks to a lot of Jason's work at my practice. He identified enclomiphene. And this is a protocol we'll use. We'll do enclomiphene 25 milligram, a DHEA, and pregnenolone dosing, oftentimes based off their hormone labs that we obtain. And we'll take it on a daily basis for these men or even alternating days. And we'll see testosterone rise between 30 or 40% in the majority of men, with very few exceptions. It does seem to work better in younger guys. Older guys, maybe less of a response. So this is a 35-year-old male. He's had consistently low testosterone levels, 400s, free testosterone of 9. I've been working with him for years until we discovered to use enclomiphene. And so we rapidly were able to almost double did double his numbers. He went up to 1,200 at one point just with this protocol, enclomiphene, DHEA, pregnenolone. But we also added a little bit of progesterone thanks to Dr. Halassa's education here in this program. where progesterone has a lot of mechanisms for where it could potentially also help with balancing high estrogens and also working as a precursor hormone as well. And he noticed the change was significant and he felt great. This is myself. I also take DHEA. There's one thing you do have to know about DHEA is if you take too much, your skin gets a little bit too oily, you can get some acne. But understanding this is very important for our aging population. What is a common complaint of the aging male? Dry skin, frail skin, maybe skin that breaks easily. You lose your moisture barrier with age, and so the skin tears, the skin rips. You get dehydrated very easily. You end up in the hospital with dehydration. So DHEA is very important for your skin health, but it also is very important as a precursor hormone of testosterone. So it can potentially help the same way testosterone might do so. So here's everything about DHEA: improves skin hydration and thickness, reduces wrinkles, improves elasticity, has anti-aging effects, wound healing and repair, skin dryness and atrophy. It can potentially prevent all of these things. So I think this is one of the most important hormones we can prescribe for the aging male. And of course, women too, but that's another lecture. We should also be measuring the pregnenolone in the aging man and female. It is the direct, it's the mother of all hormones. It's the first hormone derived from cholesterol, and from pregnenolone, all other hormones ensue. And we can supplement this as well. Our compounding pharmacies can do this. We can get this over the counter. We can prescribe it in the US. Oddly enough, I learned from my Italian functional medicine colleagues, they can't prescribe DHEA and pregnenolone in Italy. We take it for granted here. We can get it at Walmart, but it's actually a controlled substance in Italy, and they cannot prescribe it unless they're an endocrinologist or an OBGYN. I thought that was crazy, but it's true. So it's manufactured in the adrenal glands, and all steroids, hormones are from this one, and aging leads to a decrease in this marker. So let's talk about enclomiphene versus Clomid. The conventionalists, they will use the Clomid, and they'll typically have poor compliance with this product. It has a lot more side effects. It's because it's a mixture of two isomers, zuclomiphene and enclomiphene, and the zuclomiphene is the problematic one, where enclomiphene is a more pure isomer. It has a shorter half-life, doesn't have as long as a half-life as the zuclomiphene. And so what they'll do is they preserve fertility. So if you're trying to preserve fertility in your patient and he has a low testosterone, maybe they want to have kids someday, you give them the Enclo DHEA pregnenolone protocol. This is another example up here in the top right corner. We can see we improved his testosterone from the low 300s, and he had a free testosterone of 2.3, which is what you'd see in a female patient for the most part. So we were able to improve his testosterone just with this protocol from 2.3 free testosterone all the way to 13.8, and we increased his total testosterone from 378 to 736. So he was very happy about this number, and that was just with this protocol. And really, we haven't noticed any side effects with this. Here's my own hormones on this protocol. So I was also able to increase my testosterone from 540 up to 930, and from a free testosterone of 12 to 27. There's been other products, as you've seen, that have done this as well for me, but this product was very efficient. So we have to talk about the mechanism action. They both work by blocking estrogen receptors in the hypothalamus and pituitary, reducing negative feedback from circulating estrogens, such as estradiol. This tricks the brain into thinking estrogen levels are low, ramping up GnRH release, which boosts LH and FSH production to stimulate testicular testosterone synthesis. And you can also improve spermatogenesis. This is a common fertility treatment as well to improve sperm counts. Let's see. Here's more of my labs, and more on enclomiphene and Clomid. Side effects of Clomid will be mood changes, irritability, depression. That's from zuclomiphene's estrogenic effect. You can get even hot flashes. Enclomiphene, we really haven't noticed any side effects so far with it in all the patients we've used it on. But you cannot get enclomiphene at commercial pharmacies. You can get Clomid. You have to work with a compounding pharmacy, like some of our friends that might be here in the chat. So this is further on my experimentation. I was also experimenting with some other things like NP thyroid, 3 units of HGH, selenium. Doing all this, I was able to improve other biomarkers as well. And that's what we always do at the practice. We look at all the biomarkers. So I was able to improve my free T3 and T4. And of course, I was able to reduce my reverse T3 down to 6. That you'll only see with using HGH. So it does suppress reverse T3, which also improves the conversion of T4 to T3 through that mechanism. That's typically why you see children with such super high free T3 values, is because typically they'll have very high growth hormone levels in the blood, and through several mechanisms that suppresses their reverse T3 and it improves their free, which gives them so much energy and vitality. They can run circles. Literally had these kids like to come into my office, and they like to do merry-go-rounds like from my office out into the hallway through a door, and they'll go like that in a circle, and it's hard to get them to stop. They have so much energy, you can't stop them. This is a case where it didn't work. So this is a 28-year-old obese mixed Austronesian African male on our enclomiphene protocol, and he really didn't move the needle very much. He's got a lot of obesity. He's trying to reduce his carbs, trying to improve his cardio. You can see pretty bad metabolic derangement there, very high lipid particle count on the NMR up to 2,200, which he was able to reduce somewhat on our protocol, but also with a bit of cardio and reducing those carbohydrates. The carbs just were not compatible with him. And that's something you'll see in these Southeast Asian populations when they come to the US. They get really bad metabolic syndrome like very fast, unless they're really careful about their diet and training and so forth. They get the metabolic syndrome pretty quickly. Very low testosterone. So I looked into this, and I was like, well, do these populations, what's going on here? I'm not very familiar with these Southeast Asians. So it's a possibility that they have lower sex hormone binding globulin, because if you look here, his SHGB was so low, like 15 and 12. I really have never see that, especially when their free testosterone is as low as this one. His testosterone was down to 6.8, 6.5. It did come up to 11.5 with our protocol. I guess that's some of a response, but not as much as I typically see. So it's possible that Asian men have lower free testosterone than Caucasian. There's some suggestion, or they may have different polymorphins in androgen receptors, so they may respond more sensitively to lower doses of testosterone and may have a similar effect. Because he didn't really have low testosterone like symptoms. I mean, he had libido, he was obese, but it's just from the diet. So he didn't have the typical symptoms that I would see with such low testosterone levels. So potential secondary hypogonadism. Typically, I would also see LH and FSH go up in response to enclomiphene. I didn't really see that either. So very interesting case here. Let's continue here. We're going to talk more about the aromatase, estrone, and estradiol, which we talk about so much here in chronic disease prevention and management group. There's some natural ways to decrease aromatase in activity. We have to discuss those, like zinc. That's the most famous one. It's a mineral. And of course, anastrozole. And when you have increased aromatase activity, when you convert, well, this is obesity. We all know this. When you have more obesity, you're going to convert more testosterone to estrone and estradiol. And when you have more inflammation, you're eating junk food, alcohol, processed foods. You're going out to McDonald's, Chick-fil-A. This is all going to increase inflammation and increase the adiposity and increase the estrone and increase the testosterone conversion to estrone. So we have to mitigate that. So sometimes you do need to use aromatase inhibitors for these guys. We try to avoid them at the practice. We don't think you should suppress estrogen in men, because we all know estrogen is cardioprotective. So you shouldn't necessarily crush it just because it's high on the screen. If there's side effects, if there's symptoms of high estrogen, yes, maybe breast tenderness, nipple sensitivity, maybe then we'll use it. There are natural versions. There's a DIM detox. It has a couple of good products we might talk about here, or a couple of mineral herbs, I should say. I'm going to talk about one exception where I did have a bit of a positive use of using anastrozole. This was a young gentleman who was in the military. Again, military, they eat very bad. MREs, meals ready to eat, lots of stress, poor sleep. He developed terrible cystic acne during his military career, only for 4 years, but it was enough to give him permanent like cystic acne. And so he came to me and I ran a hormone test. And he's probably one of the few patients I saw with very high estriol levels. So estriol is typically found only in pregnant women at very high levels. This typically shouldn't be in men. And this was consistently high for him on several occasions. And really the only thing that improved his acne was when I put him on anastrozole for him. Because otherwise his diet, he cleaned up his diet, he was exercising, he felt pretty good, other than a bit of a sleep disorder. So why high estriol in male? We asked the AI because it's such an abnormal case. Potentially poor liver clearance, exogenous sources, like maybe he's getting it from the tap water or somewhere. Maybe there's, birth control in the tap water potentially. Adrenal influence, maybe a cortisol issue. But needless to say, it did work. So when you give aromatase inhibitors, it prevents the conversion in the periphery. Their peripheral fat cells will convert, will have a higher aromatase enzyme, and they produce more estrogens. So we can block it with the aromatase inhibitor and potentially prevent the gynecomastia, the breast tenderness, breast swelling, and the side effects. Maybe the man is tearful. He's watching a Clint Eastwood movie and he's crying. He's so emotional. This is a sign of a high estrogen man, okay? You say, did you tear up on Titanic? Letrozole. So the conventionalists, they will use aromatase inhibitors to increase testosterone in men, and it does work. Maybe they won't have the same benefit as they would with testosterone, but you will see the number go up on the lab value when you block their estrogen. So that's a common trick that endocrinologists will use. Here's some studies. Aromatase inhibitors plus weight loss improves the hormonal profile of obese hypogonadal men without causing major side effects. Well, the major side effects of this probably would be cardiovascular, because when you do lower the estrogen long term, you might see some issues with arterial hardening. So they probably never did a study on this long term with aromatase inhibitors. But in the short term, they might see some benefit. Clomiphene, we have to ask how long does it take to see the benefit? In our practice, we find it's relatively soon. But in the studies, they showed that despite increase in serum testosterone, sexual function in these elder men did not significantly improve. However, on follow-up study with an extended 4-month duration of treatment, clomiphene did demonstrate improved in sexual function in 75% of men with secondary hypogonadism. So we can tell our patients you should expect to be on the enclomiphene or clomid protocol 6 months to see an effect. Here's another example, a 61-year-old male. So we're using it in an older gentleman. Enclomiphene, progesterone, DHEA, and pregnenolone, all compounded together with our friendly compounding pharmacist. And we saw an increase in testosterone total from 228 to 489 and a free from 4.2 to 10.9. So essentially a doubling in the level. So he was pretty happy about that. We also noticed improvement in the A1C. It went from 7.1 to 6.6, so some improvement in the metabolic syndrome. His estrogen did improve. It went from 17 to 29. I call that an improvement because I actually want a little bit more estrogen in men because it is cardioprotective. His DHEA, we did overshoot it a little bit, but he didn't have any cystic acne. I think he actually liked the excess oil on his skin because his skin was a little bit dry in the first place with the DHEA level of 127. So tamoxifen is another one of these estrogen blockers. It's used in breast cancer therapy treatments. Not a huge fan of this one. I personally don't use it, but you might see some endocrinologists prescribe this off-label for men with low testosterone. Clomiphene plus anastrozole. When I worked in psychiatry, I sent a patient with low testosterone to an endocrinologist who liked to do that for men. He would do them both together. But remember, that's because Clomid has an estrogenic side effect. It's not enclomiphene. So in our practice, since we have access to enclomiphene, we don't need to use anastrozole to block estrogen. What does up to date say about testosterone benefits? Yes, of course, we all know improvement in bone density, potentially some benefit on mood, but the data is inconsistent. I mean, that's very variable. It's psychiatry and mental health is person dependent. Cognition, um, I think with the whole thing, you need to look at all the hormones for improving cognition, as Clearfield has talked about in his lectures on traumatic brain injury and prevention of Alzheimer's. All the hormones, pregnenolone, DHEA, balancing the cortisol, testosterone, estrogen, all of them will improve, I think, our cognitive capacity with age. Thyroid hormone, can't forget about that, the vitamins. So it's not just one thing. The conventional, they like to look at one thing and say, I caused this or this. But in functional medicine, we understand it's the accumulation of everything. You have to optimize all the hormones, all the vitamins to see a benefit. So we have to talk about now the mechanisms of doing testosterone replacement therapy. This black box warning, what's this? Oh, we'll talk about the pulmonary oil microembolism. That's with a certain product, not most products. So typically, oral testosterone has been poorly absorbed with GI side effects and liver problems, but this is old news. We now have a new drug on the market called Kysatrex, and it is a testosterone undecanoate. You take it orally, 200 milligrams twice daily. It has a short half-life, so you need to take it twice daily. And this has been found to be therapeutic and not having the typical side effects that we learned about even just like 5 years ago with oral testosterone therapies. So we can use this one, and it's a commercial product, but you have to still get it with compounding pharmacies. You can't. It's not like you can prescribe it with Walgreens. Walgreens won't even know what you're talking about. It does need to go with specialty pharmacies still, but easy to use, twice daily, and you can see pretty rapid rise in testosterone and pretty much a doubling in your free testosterone levels.
Is it sublingual?
No, this is oral. It is an oral testosterone. You just
It also costs $800 a month.
no, it doesn't cost that much. No, it's like 170.
Oh, okay, it must have come down. Last
Yeah.
time I looked, it was 800.
No. It's like 700.
Not worry about liver bypass?
No, there's not a concern with liver with this product, according to the studies that they're doing on this. Let me see if I can find that for you.
Did you say no? It's 700, not 800? Or are you
No,
saying
it's 170.
170? Okay, got you.
Yeah, 170. So the most common adverse effect was increased blood pressure in 2.6% of patients. I mean, you do probably still need to do some phlebotomy, and we can talk about that a little bit later. Let's see, some headaches, diarrhea, anxiety. Not much about. So Kysatrex uses a lymphatic absorption mechanism, bypassing the liver to avoid toxicity associated with the older oral testosterone formulations. This is facilitated by self-emulsifying drug delivery system with phytoestryl esters. Oh, they're using phytonutrients. That's cool. So you can do sublingual testosterone. We can get that, of course, with our compounding pharmacies to bypass that same mechanism that Dr. Iman talked about. You can do sublingual effects. You can put it on the gum. This can be a little bit irritating for some patients, but women do like it, especially when you do it like a low dose, like 5 milligram for women. It's quite effective at increasing their testosterone levels. Nasal testosterone, no one likes to do that. It's a lot of irritation to put it up the nose. You can get this commercially available, but no one likes it. Subdermal testosterone implants, a lot of our friends in anti-aging medicine, they like doing this procedure. I think they can make a little margin on it. Everyone is happy. It's easier for the patient. They don't have to apply something every day. The provider makes a little margin. But you do have the problem with injection site. It's a procedure. It's an invasive procedure. You have to inject a pellet in there. But then in my patient population, I expect them all to be training intensely. And the harder you train, the quicker you will burn through these pellets. So for my patient population, it's not the greatest choice for us. But for maybe more sedentary populations, it's okay. It's easy. You can do a procedure and you're good for maybe a couple months. Transdermal testosterone and testosterone patches. The patches are more common in women. For men, we typically use a transdermal cream or a gel. The issue with with applying it topically is that it converts more to the dihydrotestosterone. So if you're concerned about maybe male pattern baldness, or if there's a DHT irritation on the prostate, I know Morgan Tyler says that testosterone doesn't increase prostate risk, but some men will feel that their prostate gets a little irritated with testosterone, whether it's a transdermal or an injection. And so they monitor that. But you may find that more so in the transdermal applications. This is a male, 62-year-old male with a CACS of 600. The only intervention we've done so far that he wanted, and we've talked about a lot of things, diet, exercise, pharmaceutical management. He really hasn't wanted to do too much. He's been kind of dragging his feet on this. So we did testosterone therapy, and we did already see an improvement in his lipid particle count. He was upwards of 3,122, and he went down to 2,300, really with no other intervention. I mean, we're still working with this guy. We're trying to get him on board here. But a little bit of transdermal testosterone. I mean, he's feeling good libido, good strength. As far as he can open jars, but he's not going to the gym too much. So we'll be working with this guy some more to improve that. There's a couple of T gels on the market, but we get it typically with our compounding pharmacies. I'll typically do 80 milligram per ml transdermal application. They can apply it to the groin, the scrotum, shaved scrotum, mind you, axillary area, really anywhere, any place that won't be transferred to others. You have to always wash your hands after applying it, of course. Some of that up to 125, you can do 150 milligrams, even up to 200 milligrams per ml for further effects. Intramuscular injectable testosterone is the most common form of delivery mechanism for testosterone. It's been used since the 1950s. And we're going to talk about the different esters, and there's different oil carriers. So with compounding pharmacies, you can get MCT oil or sesame oil. Commercial pharmacies will have grapeseed and cottonseed oil, so maybe not the best oils, but that's the commercially available product you can get at Walgreens or Walmart. You want to inject into the buttock, you can inject into the deltoid, you can inject into the vastus lateralis. If you inject testosterone, you're going to have supraphysiologic levels, right? Depending on how much you inject. Testosterone propionate has a very quick time of onset, has a shorter half-life. You'll go back down to normal ranges within 2 days after injection. So no one does testosterone propionate typically. Testosterone cypionate is the most common injectable testosterone. It has a longer half-life, maybe up to 14 days, some suggest. Regardless, I don't have patients come into the office every 2 weeks for an injection. That's an old school method. We don't do that here. When you do long or large volume infrequent injection, this gives you a supraphysiologic level, and you aromatize towards estrogen and you convert towards DHT in excess. So ideally, you want to microdose testosterone. So for my guys, I recommend minimum is every 4 days injection. Ideally would be even alternating day injections. And for the very obese and those who convert very hard to estrone, maybe even everyday microdose with an insulin needle. So the way I have guys do that is they'll draw out the testosterone with a thicker needle, a 23 gauge. They switch out the needle and they apply a 30 gauge insulin needle. And that way they can do an injection into the deltoid. So we're talking a very fine amount of, in units even. We're talking about maybe 10 units that they're injecting of testosterone. So instead of injecting 0.5 milligrams a week or every 4 days, they're doing maybe 10 units or even 7 units intramuscular injection every day. So this is going to provide a consistent dosing and less aromatization, and you're not going to have high swings of the testosterone.
I've been doing it sub-Q with the same but great result, the microdosing, and it's easier to administer.
Yeah,
Sub-Q.
you can do sub-Q as well. Some guys, they don't like it because it leaves a little bubble on the belly. It'll absorb though, especially if you do a very small volume amount. It should
Yeah,
not
not
be
with the
noticeable.
10 units. Yeah, 10 units is perfect every other day.
Exactly. That's a great way to do it. 10 units every other day. I like that one. So again, when you're having patients always ask me this, when should I get my blood done? I tell them, if you inject and you go that day or the day next, it's going to be high. Okay. If you go 3 days after an injection, it's probably going to be lower. So injecting and then measuring is a difficult subject. You know, back in the old days when before they had anti-aging specialists like us, the guys they would trick their primary care is they would do the injection and then they would wait like 3 weeks and they go in and it would be tanked their testosterone. Look, doctor, I need more. So, I mean, you can trick the lab, you can trick your doctor, but I say, well, it's just something on the paper. We go off based how do you feel? How much are you aromatizing to? Your libido is good, your energy is good, your recovery is good, and then the lab is okay. But you take the lab result with a grain of salt, of course, because the date of injection matters. Testosterone enanthate has a bit of a slower effect, maybe not as quick a rise and fall as propionate. I'd say it's more similar to cypionate, but maybe not as high as a spike as the cypionate. You can get it in a variety of compounds. I think it's commercially available as well. They say that it peaks within 36 to 40 hours after the last dose. And plateau is reached by week 3 and 4, respectively. So that's a very long half-life. It just goes to show you the different effects. Let's see. Short-acting IMT formulation, testosterone cypionate and testosterone enanthate are associated with the most rapid and significant increase in serum T levels, with supraphysiological T levels achieved within days of an injection and a return to baseline by 10 to 14 days. But that's the old school thinking. We now all want to do microdosing and more frequent dosing. And then testosterone undecanoate, this one has super long effect. We're talking weeks to even months. And they would inject these guys with 4 mLs of this oil in a castor oil, kind of a painful procedure. And they would have to monitor these patients in the clinic for 30 minutes with this product because there's a risk of POMI, which is a pulmonary oil microembolism. And that's when you didn't aspirate correctly and you injected into a vein. You injected oil into a vein and you threw an oil clot and you killed the patient. So I don't know if anybody still does that. Maybe Dr. Crewfield, you might know somebody who does this thing. I don't think anybody does this anymore. Always aspirate too. So you can get esters, you can get a tri-blend. That's pretty popular among compounding pharmacies. CYP and enanthate propionate. You can get an 80-80-80 in some places, or 80-80-40 milligram. They say you can potentially do less frequent injections with this product. I still don't recommend it. I think it's terrible advice to do, every 30-week injection. But some guys might like this one. You offer it to the patient if they want to try a tri-blend, compare it to a cypionate. I don't think they'll notice too much of a difference, really. Let's see. So conclusions, overall hormone optimization, TRT, whether through injections or transdermal applications or adjuncts like pregnenolone and enclomiphene. The aim is to restore optimal testosterone levels, optimal, being youthful levels, between, 700 and 1,300. And this is going to improve their symptoms of fatigue, low libido, and muscle loss. These are all common with age. And we know that the age can be treated and should be treated to prevent all the problems associated with age, is what we see in conventional medicine every day. Frailty, diabetes, falls, weakness. So everything that, puts people in a nursing home, we want to prevent that from happening. So DHEA is a great complementary boost along with pregnenolone. We prefer enclomiphene over clomid due to much better tolerability and better effect. Testosterone injections for more potent effects, or when other therapies have failed, where the patient is of an older age and doesn't want to mess around with trying to boost it naturally, just wants to go for TRT. That's perfectly acceptable. I prefer more microdosed frequent injections rather than once a week or, God forbid, every 2-week injections coming into the doctor's office for your testosterone injection. No one should be doing that anymore. Every patient should be able to inject this for themselves, low dose, on a daily, alternating day, or every 4-day basis. Transdermal testosterone is fine if you want to try that. You do have a problem. It's transferable to the cat, the dogs. You got to be careful. You got to wash your hands. It does convert more to dihydrotestosterone, something to be aware of. All these drugs, testosterone or topical, injectable, they do convert more to estrogen if the patient is more obese, if the diet is very bad, if they have more inflammation. So they need to be more monitoring with this. And they can also convert the DHT. And so they do have a risk of hair loss or prostate irritation. So that's just something to monitor and mitigate that if that's happening.
Another problem with that, it has to be in a hairless area, otherwise it doesn't absorb too well.
Right. So they got to
And
shave the
rotating,
scrotum.
yes. And then when you have to also rotate because you saturate the receptors.
Rotate. So the topical may be something that can only be used for a short time before you have to eventually go to injectable. And that is all I have for today's lecture on male testosterone replacement. How did
Okay.
Deerfield?
You did pretty well. Just a couple of comments. Dr. Gordon likes a testosterone cypionate once 160 milligram, 40 milligram propionate blend, and he uses that every other day, and he uses it in a low dose. He'll use it at anywhere from 0.2 to 0.4 cc's every other day, so it's a fairly low dose. But that's a short acting and then a long acting mixed together. And it's a CME credit you're on, so I can tell you where to get it afterwards. Okay. So you did well, and you did bring out the testosterone undec in '08. I'm glad to see that. What would the difference be between just using enclomiphene as opposed to your blend? Because
Yeah, you could use it by itself, of course. Yeah.
I would think it would be a bit, somewhat less expensive, and then stuff. How much is how are you allowed to? Are we allowed to say how much?
Yeah, no, we can talk about the pricing. I mean, you can go and get it on full script or so forth, and you get DHEA, you can get pregnenolone, you can get them
Mhm.
over the counter, probably for the same price at the end of the day if you get it all compounded together.
Right. Okay. Um,
They're very
just curious.
useful. I think it's a great idea to combine because the patient's not all testosterone. So if you help them, like pregnenolone is your precursor, your DHA is another anabolic hormone, just a step away from testosterone. So I think it's a great combination, especially if you also consider progesterone. So
Mhm.
you're really doing physiologic, kind of replacement therapy versus just giving testosterone like everybody else and shooting up the estrogen, aromatizing, and all that kind of stuff. So I think it's a very practical and should be more promoted versus even doing pellets.
Right.
So yeah. Yeah. So while you're probably be at A4M in April, I am the lead off and doing male hormone optimization. It's the first lecture for AMMG
I'll miss
over
that.
at the Doral National on Thursday morning. So, and I have your formula in there.
Okay, good.
So you
Thursday
did make the
morning, I could come by.
Thursday 8 a.m.
I can come to that because we'll be there. We'll be there Wednesday night, so we can come by Thursday.
All right, I'll let him. I'll see if I can get you in.
See if you can get me in. Me and Logan will show up.
All right, okay. We'll see if we can get you in. I'm sure I can get you in. So, yeah. Other than that, I think you did a pretty good job. Um, what about Dr. Halas's, nasal spray stuff? Any go there?
I mean, it's just another cost if we're just trying to combine all of that progesterone, DHEA, pregnenolone, and clomiphene. I'll put it all in
Mhm.
one capsule for them. Yeah,
Mhm.
I'm not going to add on a second thing as
I
well.
remember a year ago or 2 years ago, we were talking about progesterone and I don't know, oxytocin as a combination. to raise
Yeah,
testosterone levels?
I've tested that out. It's just not super potent. Sometimes I've rarely had people say they notice their testosterone improve. That doesn't really happen. Maybe they notice they feel a little bit better emotionality, but then some women
Mhm.
they find they're too tearful on oxytocin. They get all emotional. So
Right.
it definitely improves emotions sometimes too much.
Hmm. Yeah. And there's and then I know you talked about the estrogen blocker. So way back when I first started doing this, at least 25 years ago, we didn't really have anything to go on. So we just followed the gym rats. So our goal for testosterone levels, the total was 1,500. We didn't know anything about free testosterone, and then we would just give them estrogen blockers till we got it to zero. That's how we started out. That didn't work out so well.
No.
We kind of came to the consensus that 7 to 900 total was an adequate amount. Anything more than that, we just started to see side effects. And I figure out a free androgen index, or you can do a bio, what is it, bioactive? Is it testosterone
Bioavailable.
bioavailable, where you take into account sex hormone binding globulin and
Mm,
albumin
yeah.
and total testosterone. And there are online you can just plug the numbers in and it'll give you the numbers. Or I actually I can do it in my head pretty much. The free androgen index, which some of the books say isn't all that great, it just uses the sex hormone binding globulin. Um, and so we do that, and we try to get that to be between 50 and 110. And that formula, if you want to know what it is total testosterone divided by 0.288 times sex hormone binding globulin.
Okay.
So 50 to 110 in men, and about 2 to 4% in women, is kind of what our goal there. Then we started hearing things about, you shouldn't block estrogen at all.
Mm.
And Dr. Rosier, with his scintillating personality, and Jake Campbell are, if you block testosterone or estrogen, you're committing malpractice and go to somebody else.
Mm-hmm.
Um, but that doesn't always work either.
No.
And so what I do now is I will leave it alone, and I'll let it rise unless they either have any type of gynecomastia, any type of breast tenderness, breast sensitivity, breast lumps, those kinds of things, emotional lability. So overly sensitive, overly weeping, as you say. And then there are some men. We're talking about men here. Some men, when their estrogen levels are high, have better libido and better erectile dysfunction. According to Jay Campbell, it's everybody, but it's not, because some men it's worse. And then when we do, bring their estrogens down somewhat, and so the sweet spot for a long time was 15 to 25, and anything over 40, we would bring it down. So for those guys that have erectile tissue or issues, and the estrogens are high, if we bring it down into that under 40, usually we see an improvement. Um, the um, the other the other issue with osteoporosis, long term in men, you really don't see that once the estrogen levels are greater than 3.5. 3.5 to 18, the studies that I have, 3.5 to 18 are about the same as greater than 18 on estrogen, all the way up to 200. Um, so if you do come on Thursday, the guy who's talking about the female hormones is Dr. Camarella. He gets his guys to, he uses pellets only. He gets the lab, and just so you know, if you're not familiar with pellets, serum testosterone levels when pellets are way totally inadequate. You can't tell anything from them. You really need to go by symptoms. But he wants his level at 2,000 for
Mhm.
testosterone, and estrogen levels at a minimum, estradiol levels of at a minimum of 150,
I remember
which
that
is
lecture.
which is crazy to me.
Yeah.
So he's doing the female lecture this time. So
Okay,
on
I can't. Well,
Thursday.
he also wants females to be super
Let me
physiologic
add,
on estrogen.
let me add something very important and critical here. Okay. First of all, the central blockage of the gonadal hormones, it's not, well, you can say testosterone, but it's not. This testosterone is not a strong central inhibitor. So people taking testosterone and they end up with gonadal atrophy. It's not because of directly from testosterone, although there's some inhibition there, but it's not as when it converts to estrogen. So the whole problem of atrophy of the gonads or atrophy of the testis when the male are taking testosterone, it's because of the conversion of testosterone to estrogen, and then estrogen causes mainly the inhibition of the gonadal hormones. That's why the cocktail of adding enclomiphene, it will definitely help to prevent testicular atrophy. Just to add that reason, and that's very important. I think with bringing it up, but just I want to emphasize on the importance of why he's doing it. It's not just to increase the testosterone, but also to prevent the testicular atrophy caused by estriol that's converted from testosterone. Okay. And what's important, it's not just building muscles. It's also very importantly is that your hormonal therapy is it's optimizing the metabolism, optimizing the metabolic health. It's not causing metabolic syndrome. So the ratios of the estrogen over estradiol and the testosterone over estradiol, those ratios are very important to be normalized. As long as normalized, you are in a good shape. Because if you're giving testosterone without saying, "Oh, I don't care about estrogen level, it's going to be high," that's not true because you end up with estrogen dominant syndrome, which leads to cortisone dominant syndrome, which leads to metabolic syndrome. Plus, you end up with gonadal atrophy. So it's very important that estrogens needs to be kept at low. And I think Dr. Stefan has a good example of somebody who has 200. Is that the 200 estrogens?
Oh yeah, that's gonna be in another lecture. Yes, but yeah, I had a guy with an estrone level of 400.
Yeah, so that's actually a disaster because that leads to estrogen dominant syndrome. That leads to
Prostate cancer and prostate hyperplasia.
Yes.
hyperplasia, gonadal atrophy. All of that is caused by the culprit is excess of estrogens, and that
Yeah.
you need to focus on. As long as your sex hormone is metabolically friendly, then you're in good shape. But if you end up causing estrogen dominant metabolic syndrome and you're building the muscles, and the patient end up with cardiac arrest or stroke, you're not doing much to the patient's health. And that's the reason why gender transition therapy, where the female relies on her estrogen dominancy as to keep her from metabolic syndrome, and you counteract it with testosterone for transition, the patient end up with metabolic syndrome, estrogen dominant syndrome, cancer, and that will compromise their immune system as well. Estrogen dominant syndrome and cortisone will suppress the Th1 immune surveillance, leading to infection and cancer. And vice versa, true for the men who are gender transition and they give them estrogen. And I think and that's the whole book about the estrogen dominant syndrome that I wrote, is that estrogen or sex hormone or embracing their sick gender versus transition, it's more healthy because the transition gender therapy leads to metabolic syndrome and all the problems. And I don't think the mainstream medicine have any clue about it. It's all about the psychological feeling of the patient. And that psychological feeling, it could be temporary, and it's because of gender dysphoria caused by estrogen dominant syndrome. And it's very important too for part of the sport medicine. If they don't care and they're just giving testosterone and all the testosterone convert to estrogen, and then that guy is having gender dysphoria, and you may end up causing a problem with those guys, and they end up with feminization.
Yeah, that's I wonder if that's ever happened. Yes, Dr. Emerling.
Well, just because you mentioned gender dysphoria, this is a condition that resolves in 90% of kids by the time they get through puberty. So treating this with hormone blockers and surgery to me is profoundly unethical and harmful. But I wanted to ask you, how do you dose DHEA and pregnenolone? Do you need levels or do you just do it clinically?
Yeah, you should measure the blood. But very obvious signs is dry skin. This is low DHEA, and high DHEA, oily skin, acne. Yeah, I had
Yeah.
that issue when I was a kid. I bet my DHEA level was like 400, 500. I've seen that in some kids with acne. I had too much oil. Now I have less oil and give myself some. If I do too much, I get acne. The signs of low pregnenolone, this might come more with age, but by that time you got bad problems with Alzheimer's. So that's something you
Great.
probably want to optimize early before there's symptoms with poor cognition, forgetfulness. You still want to treat that, obviously, but ideally optimize that before you get to that point in life.
Yeah. Pregnenolone is the hormone of memory, and we measure it on everybody. 90 to 110 is our sweet spot. I can get you the units if you need it. And we measure. I only measure DHEA. I don't measure DHEA continuously. One of the things that I've noticed since I've been doing this for like forever and a day is that we start getting a negative feedback after a while if they have adequate testosterone levels. So you give them DHEA and the levels start going down. And I'm giving them 50 and 100 and 150. They've been on testosterone for 2 or 3 years and they have pretty good levels. What we're looking for. We actually see that they go down. So I kind of give up on it after that. One of the clinical pearls, though, with DHEA is if patients have a lot of stress, high cortisol levels, DHEA is a terrific balancer of cortisol. And, we can measure a cortisol DHEA ratio. And that works nicely. And there was something else you mentioned that sort of rang a bell, and now it's my old timers is kicking in, and I'm forgetting what it was. Um, um, so what did you talk about just before we did the DHEA and pregnant? I forget. There was something I wanted to bring up, and I lost it. So anyway, carry on.
Gender transition stuff?
Oh, yes, right. Okay. So, turns out if you look at your ring finger and your index finger and look at do a ratio to them, those male dominated have a much longer ring finger than their index finger, and females are pretty much even. And so those that are gender dysphoric, you'll find that if they're females looking to be males or even tomboys, you'll find that their ring fingers are indeed much lower, much smaller than their index finger. If their index and index finger and their ring finger are about even, that's more of a female dominance, and that actually comes from testosterone in utero, the amount of testosterone in utero. So it's called a 2D to 4D ratio. And if you come to the lecture on April 20, what is it? That whatever Thursday that is, the 23rd, 24th. I actually go over that as something, as just a clue. So there you go. There's another little piece of
So my
useless information.
taller than my
I bet the ladies love that one at the bar.
ring finger is taller than index finger, so I'm good.
Dr. Halassa doesn't have a ring finger, so he's all male. Right?
I'll cut my index finger if that's the case.
There you go.
Yeah.
So
Who likes pellets and can they defend them?
I do. We do a
Okay,
lot of
tell us,
pellets.
Dr. Clearwater, tell us more.
We do a lot of pellets.
Yeah, but
we
you can't measure the patient's results, and I mean you're putting a huge amount. It will get into the blood.
Yeah, I
Higher
mean the
risk.
serum levels are totally inadequate, inaccurate. So we know that going in.
But
So
that's not true because they are serum levels and their estrogen is high, their red count is high, hematocrit is high. I mean, everything is not accurate.
no, just the testosterone levels.
No, but everything else is not physiologic. Hematocrit, red count is high. They have so
Well,
many high risks for so many things. Their estrogen goes up. They're
I don't know.
aromatizing. It's
But the
just not
patients really swear by it.
physiologic.
Yeah,
They
we've been
really love
we've been doing them for 20 years, and really, other than we have to tell them, that these serum levels aren't really accurate, and they accept it. Patients love it, and at least our patients do.
The patients will love it. You're overdosing them with a huge amount of a feel-good hormone in the beginning. Who wouldn't love it? I would love it.
Well, as long as they're giving them enclomiphene and progesterone or pregnenolone, then that may be okay. But how they are going to be compliant, the patient, unless they give, if the pill can they mix with it enclomiphene, that would be nice, and progesterone with testosterone, like a combined one. Then you can get some balancing effect there, where the patient will not end up with estrogen dominant syndrome.
I wish they would have a better slow release system. I don't know why it's not being developed.
What's that?
I don't think they have a proper slow release system, and they tell you don't measure the patient's blood. But I mean, like if you're saying that testosterone is not accurate, even your other hormones are not accurate then, even your estrogen is not accurate, your red count is high, your hematocrit is, so it is not a physiologic treatment. You're giving a huge dose. With previously people had lots of complication with BIT being sued. I guess the dosage maybe is a little bit less, but still you're creating more.
I don't know. I've been doing them for over 20 years. I never, every once in a while one will pop out, or a guy drove 12 hours after I put them in, and got the incision infected. I mean, that's not my fault. I never had any. 20 years. I've never had an issue. Okay, and some of these patients, if I tell them I'm not going to do pellets on them, I think they kill me.
Yeah, I mean, like some people don't want to use anything every day or every week or whatever. But I'm just asking like the pros and cons. Pros, yeah, lazy people that don't want to do anything, I will not do anything else, maybe put a pellet in there. But aren't they going to have like high estrogen? These are the ones you have to do all kinds of things to protect them from other reasons.
Not
Like they will
really.
have high estrogen, they're going to have red counts that they need to do venipuncture.
I don't. I didn't. I don't really notice any difference.
No.
In the incidence of them, the pellets versus the others. That's my experience.
Okay.
I have seen
You know.
lots of ladies that in our area, there's a guy who puts pellets in as his hormone replacement therapy, and then they are bleeding, and estrogen levels are so high. And we are not doing the estrogen levels as they're 30 years old. They are postmenopausal women or perimenopausal women. We don't want to raise their levels to the physiologic level very high. It's just enough so that they can tolerate and feel good, but not in a very high level, because that predisposes them to adverse effects, and we don't know that who has a bad detoxification system and the issues from that. And
Well,
predisposition to cancer, although it is a debatable issue, but at least we know that we don't want to go in a super hyperphysiologic level.
well, talk to Dr. Gersh, Felice Gersh, about that. That's what she does. So, to each his own, I guess.
I
Well,
mean,
what's
everybody has their own views, but this is my view. that I think that they
uh,
should not increase the level that they're menstruating, and then they are having the issues from that. And then when you do their blood levels, they're very high. Although you say
Right.
they're not reliable, yeah, of course they're not reliable, but high levels are high levels.
what she wants to do, Doctor, she wants to do menstruation. She wants to return the menstrual cycle again
Yeah.
for the
Yeah,
month.
I did it. I did it when I first heard that. I did a survey of about 30 or 35 of my menopausal patients, and I asked them that, what they thought about that, and the answer was universal. Are you out of your mind? That was the answer. So yeah, I know. So again, Dr. Camarella is going to be
So
talking female
very,
hormones. Give,
very strong.
he takes 7 milligrams of estradiol a day himself. That's what he told us. So
Well,
That's
let me
right.
tell you about who he is. But there are some doctors are very strong with estrogen. They think estrogen is everything, and they don't want to hear anything bad about it. In fact, shit, they don't want to hear that estrogen is harmful. Estrogen is all good all the way, and that's what they have in their mind, and
I
that's what.
know, but that is one of the reasons why physicians are being reported to for the adverse effects when they go to somebody else, and they're reported to the state boards and things like that. So one has to know where they're practicing, number one, and also not first is the whomever you are treating don't do no harm, and the second one where you are practicing you don't do any harm to yourself. You can listen to 10,000 different speakers, but you have to decide where you want to stand and where the patient health is optimal. We don't want them to be in a physiologic range, and that has to be very clear.
I'm agreeing with you, Dr. Patel.
Yeah,
I'm not.
because
I'm not disagreeing.
yeah, we are living in the year with there are so many estrogen mimics, and we I mean so much toxicity of them, and then free floating estrogen everywhere causing the adverse effects. I mean, I'm not saying that I do treat hormone replacement, but I don't bring in a estrogen. And again, what my patient tells me that how they feel is the most important. And so we give them the form to fill out. How do you feel? And that tells that, and that is if they feel great, they don't have a breast engorgement, they don't have the body doesn't swell up, they don't have a fluid retention, and etc. And then the guy was giving the testosterone also pellets in a women, and they were having so much problem for that. So I think I'm not saying that, I mean, you are experienced in pellets, but one has to be very careful about not overdoing it. Underdoing, there are always answers, but not
Well,
overdoing it.
yeah. So we dose it for men 10 milligrams a day for the pellets, and for women 1 milligram a day, which is about physiologic.
10 milligrams of what?
10 milligrams of
Okay.
testosterone for men. So they come 200 milligram, pellets. They come 200 milligram. There are 300 milligrams, but I've never used them. So if you do 1,400 milligrams, that's 140 days. Females, if you do, usually we start low. We start at 100, so that'll be for 100 days, and then we go up 150. Rarely go a little bit higher than that. So,
And what about estrogen?
I know what the formula is. Usually we give them 6 to 10 milligrams of estradiol for the same amount of time. So I have to figure out what that is exactly. 0.25 milligrams per day. Is that about right?
So how does it relate to the patches?
Well, I mean, it's the same amount, but the it's continuous for 4 to 5 months rather than having them to take the patch off every third day.
No, but there are once a week patches too, right?
Yeah, but the insurance, at least here, the insurances don't pay for it, so we don't.
Oh, okay.
The reason to use the patch is because insurance pays for the patch.
Right, right. But then you have a control over too.
Yeah. Mm-hmm.
I mean,
Yeah. Once you put the pellets in, you're kind of stuck with them for.
Yeah.
If you get
I
side.
think it's a different
So
population.
I like to say
what we are
I've
talking
had
about.
every side effect. I've caused every side effect that you could probably find in any book. So I pretty much know how to handle them. So and the good news is nothing's permanent. At worst it wears off.
So how until what age do you treat for hormone replacement?
So, yeah. So, like I said, at worst, it wears off.
No, but when they are postmenopausal or andropausal, for how many years do you treat these patients?
Well, I'll tell you the truth. I keep going. I know what the books say, but again, when these patients that have been on pellets, you tell them, okay, you're 65 now. It's 10 years. You can't have them anymore.
No, that is not true because these days 65 used to be it's much younger population as compared to before.
Well, they say 10 years.
Except in some cases, 10 years, minimum 10 years.
They say
So,
10 years.
so if they want up to 75, 80, whatever is their wish, because it does protect their bones. It's not just for the sexual health we are giving. It is we are
Bones
giving
and
for
brain.
That's it.
muscular, cardiovascular, everything. If you do it if you are in the middle or a little bit on lower side, you can do more good than having adverse effects on a higher dose.
Agree. I've been for 10 years now with Dr. Clarefield.
And it has some mental health too.
Yeah. And if I almost guarantee if I wasn't on testosterone replacement, I think I'd be dead. I think I would have been one of those veterans who shot themselves. I kid you not.
Let me make sure that people understand that when we reach out to age of 50, we switch from regenerative status of sex hormone, which drops, and then we end up with cortisone dominancy, and switch from sex hormone regenerative dominancy to cortisone dominancy, degeneration, because cortisone causes degeneration. Right. And of all the aging and all that stuff, you want to prevent that switch and prevent from cortisone dominancy. So you need to give them those sex hormone in a balanced way, with the right ratio, that's metabolically friendly doses. Then you can do it forever. You don't need to stop. Actually, if you stop it, then those patients will end up aging fast and die. They will be relying on that sex hormone regenerative part to keep the longevity effect of it for as long as they live. And I don't think it's the right thing to stop it. And you cannot, if you stop it in 1 year, they will age 10 years.
Wow. Well, we're talking about females.
It's hypothetical, Dr. Halasha. That is really hypothetical.
Right.
Yeah. And we're talking about
hormone. You stop.
Well, I mean, there are people that I have some patients that are not, as soon as you put them on a hormone replacement and they start gaining weight. Okay, back off everything, start one thing at a time and see what dose they can tolerate without gaining weight. And gaining weight can be, and in a female, when you start them on testosterone, many times they start gaining weight much faster, and we think that they should not have a weight on their middle part of the body. And when you look at the female, and if they have that, you know that the hormone deficiency is there and there is a problem. So we have to really titrate the dose,
You give them sex hormones and their body is toxic, and all the sex hormones convert in our estrogen.
Right. Yes.
then that's not going to be the treatment that I'm talking about. I'm talking about with detoxing the body, with health optimization, along with six hormone. I'm against giving six hormone without detoxing the body and without health optimization and without taking care of the oxidative stress. Because if you give them all the six hormone, they will turn into, by those endocrine disruptors and aromatase activators, into estrogen, and they will end up with weight. Yes, because of the cortisones. So you're defeating the purpose here. But what I'm trying to say is that if somebody on six hormones and then you stop them, they will end up aging fast. That this is true and fact for anybody out there who is taking six hormone. They stop it and look at him 1 year from stopping, and you will see everything. It's flaring up. Blood pressure will flare up. Cortisone dominancy, aging is what his hair will end up white completely, and that's because we are antagonizing cortisone dominancy and the degeneration. So this sex hormone, it's a regenerative molecule, but it has to be given and with health optimization. That's my thing. And actually, I learned that from Dr. Ziti Burgess one day. She said, um, she's consulting a patient or something like that, and she said, if you stop taking six hormone, you will die. But I see there is some truth there. I mean, you can say theoretically that's aggravating, but there is some truth behind it.
Well, I know this is off topic, but the recommendations from the endocrine societies and whatnot is that females 10 years past menopause are supposed to stop. They're not supposed to be taking the hormones anymore. So then what do you do?
That is because they're advocating the synthetics. That's not what we're talking about. Giving physiologic dose. I agree with Dr. Lassa.
You and I understand that, but they'll turn around and tell you it doesn't matter what it is.
Oh, because they don't know the difference between bioidentical and the synthetic. The synthetic, I will not give it even for even for free. I mean, I will not take it. The synthetic, because they are eventually they lead to oxidative stress. They're not.
Well,
the problem with all synthetic, all the drugs.
Go look up the Mayo Clinic. The Mayo Clinic's going to tell you there's no difference between the synthetics and the natural. You and I know that that's not true, but I'm telling you that it's there.
But we document that in our charts that the patient is doing much better on the hormone replacement therapy, and patient wants to remain, and we have a progress report that they fill it out that we want to continue.
They're going to tell.
Okay.
Yeah, so I went to online. I went to a British menopause conference, and their consensus is that 10 years after menopause, estrogen, even natural estrogen, causes cardiovascular deterioration.
Well, let me tell you about this. This is kind of catchy-tail. First of all,
hey, I'm just the messenger here.
Yeah, but I'm
on your side.
Saying the reason. The big pharma, they don't want the natural products to take over because it'll take their business off. So basically, it's the CEO of the big pharma is saying all this natural stuff are bad, and use the mainstream medicine or the big pharma product, synthetic one, because the synthetic one, the big pharma makes money out of it, and the other one they don't. That's
and they'll turn around and say you're using compounded products, and they're not standardized, and nobody knows what you're getting.
Yeah, that's the compounding pharmacy. It's they have the license to, and the doctors has a license to compound anything within the FDA approval. So any ingredients that's FDA approved, past safety for any application, it can be switched to another applications, and that's called repurposing drugs, and it's legal within the scope of practicing medicine.
Well,
yeah.
My approach is very simple. Whatever these specialty societies say, I do the opposite.
Well, I think we all do on this call. I'm just giving you what's out there, and when we go to AMMG, they have to answer to the ACCME, credit, and I have to put that in there as a caveat.
Right.
Not that I want to. Also, Stefan, you mentioned the Traverse study. I'm reporting on that also. That was a big study done. It's supposed to be the definitive talk on testosterone, and it was published in 2023. What they didn't tell you is that it was sponsored by Abbey, and the only testosterone product used was Androgel 1.625 patch. That was the only product used. Did you know that?
I didn't know that. Wow.
Yep. Yep. Take a look. So it's kind of useless actually, but
Wow.
they wanted me to report on that in this talk that I'm giving. So there you go.
There you go. That's what we get.
So again, it's a big hullabaloo. That's where the FDA took off the thing about heart attacks and strokes though.
Yeah.
That study, right?
Yeah, that's good.
Which was a good thing.
Yeah.
But again, it's synthetic and it was only one product. and I think the average testosterone levels in the guys in that study was around 550. So, you, use it as you may.
Yeah, exactly.
So,
all right, that was
okay.
good.
All right. Okay, guys. Tomorrow night, there's a link there. Tomorrow night, we have Dr. Tano. Who's going to regale us with cholesterol tales. So you're all welcome. 5:00 Pacific, 8:00 Eastern, and we'll do our thing, and see you then.
I'll see you then. Bye, guys.
Okay.